After that elegant session of fracture fixations, now let's move on to that when the fixation fails in certain groups of patients, need to salvage it with arthroplasty. So failed internal fixation, like in these kind of scenarios, it is very painful for the patient, and hip arthroplasty remains the most successful salvaging procedure in certain group of patients. Let's follow this algorithm. If the young patient less than 60 years with good bone stock without any avascular necrosis or arthritis, revision or fixation or osteotomy is the treatment of choice. But if the patients are more than 60 years with a poor bone stock, abductor power more than 3, then if you have to look for the acetabulum, if there is a degeneration or arthritis in the acetabulum or there is a penetration of the screw, then if the patient is young, less than 75 years, then go for a hip total hip arthroplasty, or the patient is more than 75 years and with a, maybe cognitive function is poor or not a community ambulator, then you have to go for a bipolar hemiarthroplasty. And I will focus my discussion about this arthroplasty after an intertrochanteric fractures. These are a group of difficult primary hip arthroplasties because exposure is a problem, and you need to try to incorporate the previous incision in your hip arthroplasty. I always go by the posterior approach, though literature describes anterior approach as well. There is a previous implant in situ, so you have to keep the implant removal instruments ready. There is a poor bone stock, and there is a distorted proximal anatomy of the femur which you need to negotiate, and there are screw holes which are potential fracture sites for the stress fractures, or if you are doing a cemented prosthesis, there is a possibility of extrusion of the cement through these screw holes. And there are scar tissues which are stronger than the osteoporotic bone, so you have to do adequate release in the proximal part of the femur in order to mobilize the femur, and considerable amount of shortening is there. See, the approach is that try to incorporate the previous incision. As I told you, always keep infection in mind and do the infection work of before surgery, and specific implant removal sets has to be there, and this broken screw removal set is a beautiful useful in your theater. It should be always be there while you are taking out the implant, and you expect excess of bleeding, so keep blood standby. You need to have a extensive soft tissue release, and as Abhijit told you in the lecture, that first dislocate and then relocate and do the implant removal and do the neck cut. And after taking out the implant, there is a beautiful membrane which is there. You take out that membrane and send that membrane for culture and sensitivity and histopathology to see that whether there is any occult infection there inside, and so that you can treat them post-operatively. On the femoral side, the challenges is that since there are screw holes, it is preferable to do a prophylactic wiring, lest there may be during the reaming there is a possibility of stress fracture. You need to bypass the screw holes, and you can bypass it with the standard cemented stems with the cementing. Remember, during pressurization there is extrusion of the cement through the screw holes, so you have to block the holes either with cortical strut graft or you can put your finger inside there so that cement extrusion doesn't take place. Or prefer to use a long uncemented stem which extends beyond a fully coated stem beyond the last screw hole. There is a possibility of medial displacement with a distorted anatomy, so you have to negotiate that. That I will tell you later in the later part of my lecture. And of course, if there is a trochanteric non-union, you have to fix the trochanter in different ways. But if there is a penetration of the screw like that, the algorithm is that first you take out the implant, then you dislocate. Rather than dislocating the hip, otherwise it will further damage and take out the bone stock. This is 81 years old male, DHS cutout, that is 9.5 years follow-up. The trochanter was fixed, it is flying trochanter there, trochanteric non-union there. In the earlier part, in the late 90s, early 90s, this patient was operated in 74 years old female. We used to do a cemented hip. This is a osteoporotic bone with a very wide canal, so a channelly bulky prosthesis which has been used, that is the 8 years follow-up of this patient. Or you can use nowadays in a cemented hip. This is a 62 years old female. Fixation was 1.5 years back which failed, and here is a cemented type of standard cemented hip using a exeter or CPT type of stem useful because this stem is little longer, is about 150 millimeter, and usually it will bypass the last screw holes. And that is a 6.5 years follow-up of this patient after the trochanteric union. Now this 66-year-old male failed PFN with a avascular necrosis of the hip, and this patient can be addressed with a long, fully coated stem. So you have to bypass that screw hole. That is 7-year follow-up of this patient. This is a 67-year-old female, 4-part comminuted intertrochanteric femur with a DOR C canal. And here you need to go through a trans-trochanteric approach. Harish will show you the approach in the next lecture. And here he followed a hybrid kind of fixation because there is a DOR type C canal, and used a multi-hole cup for a better fixation. While using a multi-hole cup, try to develop a technique so that you can pass the screw inside the pubis like this, so that it have a divergent fixation and a better fixation in different directions. Of course, the trochanteric wiring, one need to learn the techniques of the trochanteric wiring, and that is 6 years follow-up of this patient. Sometimes you may prefer to do a 2-stage surgery. This is a case with culprit from Dr. Atul Pangate, where they have done a 2-stage surgery after implant removal. If it is a tedious implant removal, or you suspect there is a occult infection, you can take out the implant and leave it like that, and later on convert to a hip replacement surgery. But where you have confirmed infection, a 54-year-old female failed infected dynamic hip screw, you need to put a cement spacer first in the first stage, and in the second stage you have to convert to a hip replacement surgery. That is 8 years follow-up of this patient with the abductor lurch there because of this, stress shielding there, and there is a disappearance of the lateral cortex there. When there is a peri-implant fracture, this is likely there is a challenge of coxa vara, coxa breva. You need to reduce the fracture before rimming. So do a prophylactic airing, then reduce this fracture and hold it with a plate with 2 plate holding forceps before rimming. Then you can put a long stem which gives adequate fixation, and that is 5 years follow-up of this patient after, with a long grid blasted, this Wagner type of stem. When there is a peri-implant fracture like the broken PFN like that, then here if there is a challenge of holding the plate, so here the bone holding portion didn't work out, so you can put a plate and just do a wiring. It is staggered wiring like this, gives a adequate stability. Then you can rim the canal, and that is 1.5 years follow-up of this patient. When there is a malunion of the fracture at the metaphyseal region, these are little complex cases. So if there is a metaphyseal valgus, your entry point should be on the medial side near the calcar rather than the usual lateral entry, and you can use a small cemented stem or a modular stem. But if there is a metaphyseal varus deformity, you can use a conventional implant and do a overhanging retrotrochanteric osteotomy. But if there is a metaphyseal rotational deformity, you can use a small cemented stem or a diaphyseal fixation stem. And during the rimming, one has to be very careful that you should keep your high-speed bars or rimmers or flexible rimmers there, and implant malposition, bone impingement possibility there, otherwise it lead to instability. This is a patient with proximal femoral displacement osteotomy, where you have to do a medial entry point in this kind of cases, and that is the 3 years follow-up of this patient. This case I was going to highlight that a 62-year-old female fixed 8 months back, and she has a varus arthritic knee. Because of the varus bending moment, there is probably a cutout of the implant. We did a hybrid type of fixation there, but still because of the varus bending moment, there was a periprosthetic fracture which was ultimately, plating was done and subsequently it united. Finally, there is a, the possibility of intraoperative fracture in this kind of patient, 64 years old male with this type of, bone loss there. There is intraoperative retrotrochanteric fracture, cemented hip was done. This was way back in 2007, and that is 7 years follow-up of a union of the greater trochanter. Post-operatively, these patients require prolonged period of rehabilitation. There is increased chances of dislocation. Of course, nowadays dual mobility hips are preferable to prevent this kind of dislocation, and there is a high mortality rate associated, remember, and the rate of mortality is comparable to the mortality in the primary hip fracture state during this age group. We have published this in Indian Journal of Orthopedics in 2013. You can go through it for further reading. So to conclude, dear friends, total hip arthroplasty is an effective salvage procedure for failed internal fixation of hip fracture. Most patients get significant pain relief and functional improvement because of early mobilization of this patient. Fractures are more likely to occur with bony deformity in osteoporotic bone, and these are a group of technically difficult surgery. But remember, all the technical difficult surgery does not necessarily translate into a poorer outcome. I thank you for a patient hearing.
Thank you.